So these are the key questions as we look at the reverse shoulder arthroplasty. Here's Christian Gerber, who one was my mentors and friends many years ago. How important is the subscap in the first place in reverse shoulder arthroplasty? I recall in the very beginning there were some concerns that the subscapularis in the setting of reverse shoulder arthroplasty may be a contributor to instability, and so many of us would routinely ignore the subscapularis in the setting of reverse shoulder arthroplasty. That thinking and dogma has obviously changed today. And so this remains one question. And the second question is, to what degree does repairing the subscap have an effect on the overall functional outcome of reverse shoulder arthroplasty? Are we perhaps overpowering the remnant short external rotators, the teres minor, remnant of infraspinatus? These are still unanswered questions. And as we move to the Arthrex reverse system, it's, as we know, the only implant design which gives the surgeon the option of having a more Grammont-style horizontal angle of inclination of the humerus versus the 135-degree more anatomic design. So what impact does this geometry have on our subscap repair? And then I want to touch a little bit on technical pearls and obviously postoperative rehabilitation, which also plays a role. So we know from various contributors that the subscapularis is the largest rotator cuff muscle. It accounts for 54% of rotator cuff volume. And it is not only an internal rotator, as we know, but it also acts to compress the joint and optimize the function of the remainder rotator cuff throughout our arc of function. It optimizes function of the deltoid and the posterior rotator cuff in overhead motion. It provides a fixed fulcrum of rotation relative to the glenoid. But how important are these features in the reverse, which is a very constrained articulation? So we know in non-constrained shoulder arthroplasty, the subscap is critical. It's critical in functional improvement following shoulder arthroplasty. Insufficiency can lead to both static and dynamic anterior subluxation of the humerus. This can lead to glenoid eccentric loading, potentially loosening, rocking horse effects, poor coordination of deltoid contraction, ultimately pain and dysfunction. And so, as Evan showed earlier on the axillary lateral, it's quite easy to appreciate subscapularis insufficiency with static anterior subluxation of the humeral component. It's a common cause of revision, and the reports in the literature have indicated this occurrence. The physical examination to assess the subscap is well described, and I like to use lag signs to assess this. The modified liftoff test is a very useful test for the examiner. And for patients that have difficulty getting behind their back, the modified belly press test can also be an internal lag sign which can nicely document the presence or absence of subscapularis integrity. Imaging is very useful, and at least in my hands, a CT scan is a routine part of preoperative planning for shoulder arthroplasty. And aside from really appreciating glenoid version and retroversion, which is most reliably quantified on CT scan, I'm also trying to get a sense of the rotator cuff before getting into the operating room, and primarily looking at the subscapularis. And so when we get into a setting based on Goutalier's staging system of stage 3 or 4 fatty infiltration, we're probably not going to be considering a non-constrained shoulder arthroplasty and going right to reverse. The surgical technique includes beach chair positioning. I like interscaling catheter placement, which allows for relaxation during and postoperative analgesia. Various approaches have been described for the reverse, including a superior approach, which is not an approach that I will use, and an articulated arm holder is also quite useful. As we all know, in shoulder arthroplasty, the releases are really the critical step, and when we're thinking about the subscapularis, I think it's very important to release those adhesions deep to the conjoint tendon, and a biceps tenodesis for me is a routine part of the operation. Now, when we get to the subscapularis, I think it's important, as has been highlighted earlier, to release the rotator interval to the base of the coracoid. And once we identify the axillary nerve, it's much more safe and effective to perform a 360-degree release of the subscapularis. Now, the takedown itself, there's really 3 methods, and I will say that I've never had a good appreciation or affinity for a medial takedown. Conceptually, I've had an issue with cutting through native tendon, and so for me at least, the lesser tuberosity osteotomy is something that I learned in Switzerland many years ago. And it's not only used in shoulder arthroplasty, but I remember operating next to Dr. Gons. He would routinely use lateral vastus lateralis osteotomies for hip exposure. And so we have the takedown, we have the peel down technique, which probably gives the surgeon the most variability and flexibility with how they want to repair the subscap, and that's my preferred method of choice today. and then obviously the lesser tuberosity osteotomy. And so the advantages of the LTO have been described and reported in the literature. We talked about Peter Millett's work and Brent Ponce's work. Bone-to-bone healing is obviously preferred versus tendon-to-bone healing. And so biomechanically, at least, the strength of repair has been espoused to be improved, although more recent work by Evan Letterman in the lab has shown that perhaps it's equivalent to a more robust soft tissue technique going through the actual prosthesis. So a subscapularis release, a 360-degree release is effective, and I think that one of the pearls which is very helpful is releasing the subscap from the anterior scapular body. And so I like to take some curved mayos or a cob to really release this all the way down, and so this gives us free lateral excursion of the musculotendinous unit under traction, which gives us a little bit more flexibility where we want to repair the subscap based on the geometry of the reverse. So we talked a little bit about the design features of the Arthrex reverse, and so there's still some variation in thinking. What's the decision-making process for a surgeon to choose one orientation or the other? I will say that with a 135-degree cut, we have a larger footprint or preservation of the lesser tuberosity, and so at least on that note, it might be a preferential. We also find that with glenospheres placed in more lateral offset, like the +4 design, we're lateralized in the center of rotation, and so the combination of a more distal center of rotation with lateralization can oftentimes increase your tension on your subscap and during your subsequent repair. And so at least in my hands, I like to take a repair technique which involves bone tunnels through the lesser tuberosity and cerclage the sutures around the stem. And for me, that has been a very robust repair with added flexibility. Rehabilitation is relatively straightforward, and so we just need to protect that until we move to a minimally invasive technique down the road, hopefully sooner than later. So this is a patient of mine from many years ago who had had 2 failed rotator cuff repairs. We see evidence of rotator cuff tear arthropathy, proximal migration, advanced fatty infiltration, good preservation of bone stock, and she did relatively well with, in this case, a 155-degree angle of inclination, standard glenosphere, and did relatively well. We reported on my early experience of the reverse beginning in 2005 in 265 consecutive reverse total shoulders, and we were able to review 239 of these patients with a mean follow-up of just over 2 years. As expected, we found significant improvements in pain and function post-op. The revision rate was 8%, which included primarily instability, and this really reflected our early experience of the reverse in the United States. But what we found was that there was no correlation between subscapularis repair or not and the evidence or presence or absence of instability or functional outcomes. This study by Dr. Hawkins, who's here today, he reported on 120 patients, 65 of which underwent repair of the subscapularis in reverse shoulder arthroplasty, and in his hands at least found no correlation between subscapularis repair and the presence or absence of postoperative instability in the reverse shoulder. In contrast, these 2 studies, one by Brad Edwards and the other by Greg Nicholson's group, they did find a positive correlation between the presence or absence of subscap repair with reverse shoulder arthroplasty and the presence or absence of instability. However, if you look at these studies a little bit more closely, they didn't control for the diagnosis at hand, and so many of the cases of instability without subscap repair occurred in patients who had revision hemiarthroplasty or fractures, so other diagnoses which we all know are at increased risk of instability to begin with. So in conclusion, I think that repair should be attempted as patients benefit from added rotation, internal rotation strength. I have not found it to be an issue as far as overpowering remnant posterior cuff, teres minor, and remnant infraspinatus. I think ultimately the impact of the subscap repair continues to be somewhat controversial, and we need to study this a little bit more closely. I think that repair with a 135-degree angle of inclination in the Arthrex reverse setting, which seems to be the choice of most surgeons today, is a more attractive repair for repairing the subscapularis because there's greater footprint allowed onto the lesser tuberosity, and it's a more anatomic repair. However, if repair is not possible because either the excursion is not adequate or there's poor muscle or tendon quality, I think it's not something to worry about too much. It's a constrained articulation. I don't believe that it contributes to instability that much, so I don't worry about it too much. Patients will still benefit tremendously from reverse shoulder arthroplasty.